review of local therapies in advanced pancreatic carcinomas.
Thanks again. Excellent presentation, Dr. Ahmed. Difficult to follow up now. So I'm going to look at some therapies in local regional therapies for pancreatic cancer. So to start off, pancreatic carcinoma is the 10th commonest cancer in the UK, but 5th commonest cause of cancer death. 80% of the pancreatic cancers are unresectable at presentation, and 35% of the patients have locally advanced disease, i.e. stage 3 disease. 50% of patients also have metastases at presentation, so stage 4 disease. Overall 5-year survival rate is dismal at 9%, worst of all cancers. That's because it's limited in response to chemotherapy. Is there a need for local ablation in locally advanced pancreatic cancer? Yes. Half of the deaths in pancreatic cancer are due to local progression. Local control improves survival, and local control is an important palliative tool to control the pain. In resectable pancreatic cancer, survival rates which vary between 12 to 18 months, are greatly improved when you get an R0 resection. And if you do get a wide R0 resection, the survival rates are even better, which go up to almost doubling at 35 months. So what are the ablative techniques we have currently? There are thermal ablative techniques, as like in the liver. The radiofrequency and microwave ablation that used to be tried in the past, and cryo and HIFU also have tried with mixed responses. We also have non-thermal techniques, the photodynamic therapy, which is again not widely used, very little evidence base in the literature, and there is IRE, which is now sort of emerging as a more and more popular treatment option for locally advanced pancreatic cancer. So just look at the thermal ablative techniques first of all. RFA obviously is the most commonly used ablative technique. Most of these were performed in the last decade, and majority of these were performed intraoperatively. And there are one or two studies which suggest this is a technique that could also be performed using endoscopic ultrasound guidance. The initial study showed good tumor necrosis, pain control, but also quite high complication rates, with the morbidity rates ranging between 4 and 37%, and mortality rate ranging between 0 to 25%. The majority of the complications are because of the local bowel injury, GI bleed, perforation, and also vascular injury like portal vein thrombosis. Some of the later studies, however, suggested slightly lower complications, particularly when they used low temperature RFA instead of using 105 degrees. They used a low temperature as 90 degrees, which suggested slightly better morbidity and mortality rates. And these are all the studies that are there in the literature currently looking at RFA as a local regional option for pancreatic cancer. But as you can see, all of these studies are done intraoperatively. There's just one study which was performed under endoscopic ultrasound guidance. The largest two studies, in fact, were from 2013, which had 100 patients in each group. The mortality rate varies between center to center. I mean, if you look at the bigger studies, they report a mortality rate of 3% and a morbidity rate of 24%. So it varies. So varies between center, but some of the smaller studies, particularly this study here, shows a mortality rate of 25%, but there are only 16 patients. So I think it's just variable. Perhaps if it's done in a larger center with the high volume patients, then you tend to get better results. So what about microwave ablation? Microwave, as we know, is an electromagnetic, uses electromagnetic field. There is better prediction of the ablation field. Its experience in pancreas is extremely limited. The largest series is only about 15 patients. No procedure-related morbidity or mortality has been described, and there is also no robust survival data either. What about cryoablation? Cryo works by cooling the tumor, leading to an ice ball formation and tumor necrosis. Again, the evidence base for this is extremely limited, only a few case reports. Complication rates, however, seem to be quite high, even in those select group of patients. Majority of them report a high incidence of tract bleeding, and the overall survival in those reported studies is only 5 months, so it's not great. What about HIFU? High intensity focused ultrasound is an emerging ultrasound-based technique causing thermal destruction. It causes high amplitude pressure waves, causes boiling of water molecules, and results in tumor destruction. Usually done under ultrasound guidance. It can also be done under MR guidance, quite a complex technique under MR. The evidence base for this is limited. A median overall survival in the 10 studies that is reported is between 8 and 14 months. So these are all the studies looking at HIFU as a modality for treating pancreatic cancer. And again, you can see majority of these, the largest study has about 100 patients in it, and this reports a morbidity rate of 23% here. But again, the median overall survival is about 8.3 months. So again, not widely used. So let's look at irreversible electroporation. As I mentioned previously, it's a non-thermal technique. It uses high voltage electricity to cause tumor destruction by damaging the tumor, damaging the cell wall and causing the cell death by apoptosis. And it creates nanopores which allows macromolecules to move out of the cell, and that's how cell death occurs by apoptosis. This is a schematic illustration of what happens in an IRE. You produce high voltage electricity on either side of the cell, you create permanent holes in the cell membrane, and these permanent holes will cause cell death by allowing molecules to move out of the cell. The advantages are it produces a sharply demarcated treatment area. It spares the connective tissue architecture, which means that you tend less likely to cause damage to the vessels and ducts within the treated zone. And also because IRE relies on electrical energy, not thermal energy, there is no concern regarding heat sink. What are the disadvantages? IRE is a complex technique. It requires needle placements to be very precise. You need to place the needles very symmetrically, with allowing a distance of 2 centimeters between the needles and as parallel as possible to create that symmetric, strong electric field that is necessary for tumor destruction. The contraindications are pacemakers, patient with uncontrolled arrhythmias are also a contraindication, and patients who've got metal stents. Some say it's a relative contraindication, but I did find it very challenging when doing IRE in the presence of metal stent, because you often cannot produce a strong electric field because there is quite a lot of aberration in the currents in the area, and that will mean that you do a suboptimal sort of ablation. That's my experience, but there is some literature out there saying that it can be done with metal stents and reasonably safely. IRE in pancreatic tumors can be used in the inoperable setting when the patient has completed FOLFIRINOX, or patient has completed 2 lines of chemotherapy and the tumor is still confined to the pancreas without any evidence of metastases elsewhere, and you exhausted all treatment options. So it's used as a local control in that setting as a palliative measure. But more and more IRE is now being used as a margin accentuation technique for borderline pancreatic cancers, borderline resectable pancreatic cancers in the intraoperative setting. In the neuroendocrine therapy, there's a limited evidence to suggest that can be used in patients who are not suitable for surgery. So this is the protocol we tend to follow in my hospital. When we see a pancreatic cancer, which is stage 3 with portal vein and artery encasement, we tend to give neoadjuvant chemotherapy. And if the patient demonstrates good responsive, it's stable disease but still remains inoperable because of vascular encasement, what we tend to do is we either consider referring the patient for radiotherapy or doing a percutaneous IRE as a palliative local control option. If the patient demonstrates a good radiological response and the tumor shrinks and goes well away from the vessels, then we tend to do an exploratory laparotomy. And at laparotomy, if you do find the tumor to be operable, then we do a margin accentuation with IRE followed by a Whipple's resection. If the tumor is found to be inoperable at laparotomy, what we tend to do is we do an in situ IRE, and when we do a palliative bypass surgery to the liver. So this is an example of a percutaneous IRE for a locally advanced pancreatic cancer. Young woman in her 50s, completed 2 lines of chemotherapy. The tumor hasn't responded well, and you can see there's complete encasement of the portal vein. The portal vein encasement goes well down to the SMV, so which means that resection is really not an option here. And you can also see the artery, the SMA is also in continuity with the tumor. So we did an in situ percutaneous IRE using 4 needles, as you can see there, and this is the immediate post-treatment response. You can see the tumor appears slightly devascularized, but more importantly, the vessels seem patent here. And this is the follow-up scan, which was performed 3 months afterwards. You can see there's been a size reduction of the tumor. This is essentially for palliative local control of the tumor and prolong the survival. Okay. And this is an example of a stage 3 tumor, again showing circumferential venous encasement and partial encasement of the artery as well, showing a good response to chemotherapy after 12 cycles. So this is a patient who's brought in for a trial resection. A trial resection, it was found to be operable. So what we tend to do is what we call as a margin accentuation. When we do margin accentuation, we accentuate 3 margins where you are likely to get R1 rate, where you likely get a positive resection margin. The margins which we do are the pancreatic neck margin, and this is we ablate this by putting needles directly using ultrasound guidance. Identify the tumor with ultrasound guidance, go slightly lateral to the tumor, identify the pancreatic duct, and you put 2 needles on either side of the pancreatic duct, and you ablate that margin first. And you often resect here, so slightly lateral to the ablated zone. So you're not touching the area where the pancreatic or jejunostomy is. So if you're worried about leaks, that's not an issue. So the second margin we ablate is the SMV margin, where we put 2 needles in a cradiocaudal plane in the axis parallel to the SMV, and we ablate that. The third margin which we ablate is the posterior margin, and we ablate that by using, initially we put 2 needles transjudinally, like that here, and then once this margin is complete, we remove the first needle and put it down here to ablate all that posterior margin. So one of my colleagues is a strong believer that posterior margin is always as important as the other 2 margins, hence the reason why we do that. And this is the post-resection specimen here, the gross specimen clearly showing the SMA, the SMV groove here showing significant necrosis of the area, and you also see the histology. This is the viable pancreatic gland here. This is the treated zone, and you can see the resection margins are well clear of any tumor. There are some tumor cells here, but I think most of the resection margin is clear. There's at least a centimeter away. There's no residual viable disease here. So what is the evidence base for IRE in locally advanced pancreatic cancer? There are 14 single-arm studies that have been published, both as a local treatment and in a palliative setting, and also as a margin accentuation setting as well. These were percutaneous and intraoperative studies, so there is a sort of heterogeneity in that cohort of patients. The median follow-up ranged between 1 and 29 months, and the median overall survival from diagnosis ranged between 15.3 months to 27 months, with the higher survival rate seen in those patients who went on to have a Whipple's after margin accentuation for stage 3 disease. The risk of major complications, i.e. grade 3 complications requiring prolonged hospital admission or interventions, is relatively low at 13%. And the mortality rates were not reported in all the studies. Morbidity rates, meaning pancreatitis and all of those requiring analgesia and pain therapy, was ranged between 10 and 57%. A majority of those were within the first 3 weeks after the surgery or after the treatment. And this is all the studies that are published in the last sort of 15 years with IRE as a local regional treatment option in pancreatic cancer. I'm running out of time, so I'm just going to be very quick. The largest intraoperative study is the Rob Martin's group from Louisville in Kentucky. This is an open ablative technique. They treated 200 patients, multi-center study. 50 patients were done as a margin accentuation, 150 for a local treatment, and they reported a median overall survival of 24.9 months, so which is actually double than what is expected than what is known from a pancreatic cancer. The largest percutaneous study was the Raj Narayan's group from Miami, and they treated 50 patients. And they reported a median overall survival of 27 months after treatment. So there is a prospective randomized trial as well, which is a PanFire-2 trial, which is a multi-center study, which is just concluded in Amsterdam, in Netherlands. They treated 50 patients with locally advanced pancreatic cancer. They reported a median overall survival of 10 months from IRE and 17 months from diagnosis. And there's no survival benefit in patients who received FOLFIRINOX versus gemcitabine versus no chemotherapy, suggesting IRE was a key determinant for better survival. There's another prospective trial comparing IRE versus stereotactic radiotherapy, and it again showed that propensity score matching suggested that the overall survival was better with IRE in the IRE group compared to the radiotherapy group as well. So where do we go from here? Immunotherapy seems to be exciting. Pancreatic stroma is often immunosuppressive. So using IRE often alleviates immunosuppression, and if you supplement that by using immunomodulatory therapies, then you often get a better response and often abscopal effect if there is distant metastatic disease as well. This is something which is very exciting, and there is more and more research which is just coming out, which showing that this is something that is that's to look out for. So to conclude, pancreatic cancer is a complex disease. Small percentage of patients are suitable for surgery. Conventional chemotherapy and radiotherapy haven't made a significant survival benefit. So minimally local ablative therapies in combination with chemotherapy or chemoradiotherapy are promising, but there is still a paucity of level 1 data that has to be said. IRE among all local ablative techniques has shown to be safe and effective with improved survival, improved overall survival. IRE with immunotherapy offers a glimmer of hope for future. Thank you so much again.
Thank you, dear Dr. Praveen Peddu, for your nice presentation. I have only one question, please.
Sure.
Most of the advanced pancreas tumors are associated with lymph nodes infiltration as well as liver metastasis. So what would be your IR decision for the management of such cases?
So in the palliative setting, right? So in the palliative setting, what we do is these patients have 2 lines of chemotherapy, usually a combination of FOLFIRINOX or Gem/Abraxane. And what you want to do is to demonstrate tumor stability and tumor size, ideally less than 4 centimeters, without significant nodal disease or without any evidence of extra pancreatic disease. So provided you demonstrated that, then you could use IRE as a palliative option just for better local control. We have done that in patients who had lymph nodes, but what we tend to do is to do a PET scan in that setting to see if those nodes are actually reactive or actually metastatic. So that also helps in deciding whether using IRE is an option in terms of offering better local control and thereby better prognosis. Yeah.
Thank you so much, Dr. Praveen. Great presentation, great